Fantastic. I really feel like I heard some very interesting things. I want to just start with one question, which is it seemed like each of you, in your own ways, addressed different parts of different types of ways that to think more broadly about teams, and who's part of was one of the words that many of you used. If it's the primary care providers in the patient-centered medical home, if it's going to be navigators, nurses, insurers, family caregivers, just broadening our notion of who's involved with the goal of, massively improving education, empowerment, activation to ameliorate health literacy barriers. So, this is a kind of a complicated. It's more complex than ways many people think about these types of issues. So maybe if you would each take an opportunity to make, if there's any additional concrete recommendations for how to push us towards either interventions or implementation work to broaden how we think about teams and all the different people that need to be part of this.
I can start. I just finished doing a rapid ethnography of bright spots in team-based primary care and the safety net. And there were two observations, one from the anthropologist on our team, Dr. Sarah Ackerman. She said, I'm very interested in this phrase you use, working at the top of your license, which we heard multiple times in multiple presentations. And this is why I really enjoy working with social scientists, because we take those terms for granted. And she said, to me, it looks like you are not paying medical assistants more, but you're actually giving them a great deal more responsibility, not only in terms of adding additional tasks, but also encouraging them to take some ownership over the patient and their well-being, which traditionally has not been part of their job. And you as a primary care physician tell me this is part of what adds emotional weight and emotional labor to your work. So think about what the downside is, or why that might be challenging to get people to work at the top of their license. So that's one observation about team-based care. The second observation I want to make about team-based care is that there's a lot of resistance from patients and families. Okay. I think many of you who are part of practice teams will hear from patients, well, I need to talk to my doctor about it. Why are you answering this question? I want my doctor. When is Dr. Sarkar going to be back in the clinic? So the public education piece of it's actually better for you if we work in teams hasn't even really started.
I'll go ahead and build on that. So that's one of the things that when you have that outreach from the Humana nurse, right, is helping the patient, our member, think about who that care team is, right, and what role different individuals can play for them, so that they understand that, a nutritionist is part of my care team. These are the types of questions and things that I can pose to different people on my care team, and I can be confident in the guidance that they're going to give me and the information that they're going to give me, and not everything has to come, right, from that doctor. But if they don't have the reassurance, right, I mean, the doctor, their primary care physician, their oncologist, whoever, whatever your health case, right, those are the trusted resource, the people that they are the patients are looking for to drive their care. So if they don't understand that that doctor, is a part of a larger team, and that doctor embraces that larger team and the support that they can give the patient, it's almost like they need both the knowledge of the broader care team and what's available to them, and the permission, right, and encouragement from their doctor to utilize them.
There we go. I'm going to push back a little bit, too, on the patients want to hear from their providers or their physician. So I think that's absolutely true when it's the time they need to see their physician, right? And it's back to Mandy's statement about it's who's doing the interaction, why, and for what reason, right? So absolutely, patients don't want to hear for the first time that they're diagnosed with cancer and what their treatment plan is from anybody but their physician. But they don't necessarily want to talk about sexuality and intimacy with their with their physician. They shouldn't need, most physicians in our clinical practice don't want to talk about that either. And there are other people who are trained and tooled up to do that. So it's when you match the task with the person to ensure that patients are getting the value of the expertise from all different team members. And then my last point would just be to emphasize that we just have to, from the very beginning, be very honest with patients and their caregivers about what we're going to be asking of them, that they are essential members of the healthcare team, and that their care will fail if they are not an integral part, that they have the autonomy and the voice to give us the essential information that we don't get without them bringing it to us.
So I think I'd like to kind of just highlight a point that I made in my presentation in terms of organizational context. And I think that in terms of team-based care and the importance of teams, there's a couple of things working against us. One is that very entrenched hierarchies that are in health care professional training, and that this idea of working at the top of your license, working within your scope of practice, unless we are respecting the diversity of skills and scope of what each team member does, we're not going to get there. And I also really, really, really strongly believe that culture is critical. And if we are not creating cultures that are based on trust and learning, that team members are not able to do their best job. They're not able to bring forward things that could be more efficient or more patient-centered or work better in the system if they are intimidated by the hierarchies.
I see another risk. I think that frequently systems used a team-based model to then say, oh, we've diversified our group, and that's just not enough. So, like, in fact, there needs to be physicians who can talk about sexual health. There needs to be, a diverse workforce across the spectrum, across the team. And right now, they say, oh, look, we've diversified our workforce, but actually at the lowest pay possible. And that's like deeply disturbing. Okay, so I wanted to bring up another thing, which was a new thing that came up in this talk that you brought up, Heidi, was about the family caregiver. And so, there's this untapped vista, in my perspective, about the health literacy agenda for that type of a person, and really for other team members too. So you mentioned, Mindy, about that you do literacy training for the navigators, but what does that look like? What could that look like for family caregivers as well?
I'm not sure. Words are coming out of my mouth before I've really thought about this. I think it's tricky, because I think while, for example, our navigation training, which is freely available online, and our team training, which is freely available online, could be accessed and family members could benefit very much from that, I also worry about caregiver burnout and unpaid, uncompensated caregiving. And I don't know that I have a solution for that, because I think it's critical. I think family caregivers are critical to the solution, but we undervalue them, right? Like, we don't give credit there. So I'm going to continue to think on that, but I think that there are similar opportunities for caregivers to learn. I'm not sure that it's fair, and that we're providing the kinds of social support and to make it kind of viable for caregivers to be doing that, So I'll leave it there.
So, so they're doing it already, right?
At what cost?
At what cost, right. So, so there are, in the research literature, there are a wide range of studies around supporting caregivers, right, and the value of supporting caregivers. So we know that caregivers who engage in caregiving over time are at higher risk for depression, higher risk for anxiety, higher risk for chronic disease development or exacerbation. So they actually become the next patients, right? So there's a huge reason for the healthcare system already to invest in caregivers. There's less evidence about the benefit of explicit caregiver support education on patient outcomes, but that's not been looked at as much. So, but we do know that distressed or overburdened caregivers, there are poorer outcomes for the patients that they care for. So I think it's an imperative to do this. How we do it is another way. So it's another question. But so we've heard about training for navigators that are, how long is your program? How many modules? And
It's about 20 hours.
So 20 hours. We heard yesterday for ACS that their call providers have 8 weeks of training. Medical assistants go through extensive training. We say it's important because they are caring for them. So I don't think there's a good caregiver support program that tools them up to do this care without talking about 8+ 1 hour sessions, right? Because you can't address health literacy sorts of issues and get to know the unique needs of caregivers without something that's that extensive. So I don't know if that answers the question.
I guess I'll just add to that, even though I didn't have a complete answer, I absolutely think that, caregiver and social support structures are critical for the viability of healthcare to work. We can't pay everyone to take care of every single need. And I think what's exciting about this conversation, health literacy, is, we really want to be not just doing things for patients, but helping patients self-advocate, helping patients and caregivers build skills and to bring them forward. But I think, as I mentioned in my talk, we have a dearth of social workers. I think really the mental health care piece is we need to be providing really good mental health support for caregivers and social support for caregivers if we're expecting people to take on this role. What are we doing to make sure that caregivers stay well?
I'll just add that I think there's a systems thinking piece to that. I have a colleague who's a physician whose son underwent a bone marrow transplant at a very young age. And a barrier to offering mental health support to parents whose children are going to spend literally months in the hospital, they all need mental health support. But our hospital where she had her bone marrow transplant, not San Francisco General, but the UCSF Health, they didn't have a way to enter parents who were not insured through UCSF Health into the system to give them a medical record number so that there could actually be a mental health provider assigned to them, even though they come from all over and stay in San Francisco for months. So I think we need to think about, why does everybody need a navigator so badly? Are there system changes we can make so that some people need navigation, but it's not so poorly designed for the way our patients and their families live generally?
Yeah, I think there's several calls over the last decade from NIH about caregivers and research in that space, and I don't recall any explicit call within that about health literacy, but I think it seems like a fantastic, there's a finger up in the air. Yes, please. Yes.
So the PAR for informal caregivers is being renewed and it will come out, and I believe, because I think I was partly responsible, there's language on communication and health literacy.
Fantastic.
And it's really calling for a multi-level approaches, which is multi-level intervention and measurement, which is hard to do, but I think important.
Excellent. With that, maybe we can stay at that microphone. Is that okay? Thank you. Yeah.
Thanks. Randall Oyer, Lancaster General Penn Medicine. Great talk. My question is for Mandy. You clearly said you were not asking for payment for navigators, but you showed their value. You spoke about then sort of transitioning to recognizing the value for team care. I'd like more of your thoughts on that, because we're getting clear signals from CMMI that future payment models are going to disconnect payment from volume of services, that we're going to be looking at payment for the whole, not for parts. So I'd like, in terms of policy, I'd like your more thoughts on that from you or any of the other panel members.
Sure. And just to be clear, I am not trying to say that I don't think navigators should be paid for. I was trying to say I don't think that adding it as another provider to separately bill as a fee for service would be helpful. So I do think that quantifying plans for assessing barriers, creating meaningful strides to address those barriers through a navigation process, which the COC requires in terms of navigation process, as a component of quality care for value-based purchasing or team-based payment is critical. And that I do think that there's value in calling out the navigation role in the navigation process because, it's very easy to kind of reallocate resources to all kinds of different things. So I do think there needs to be some structure of what quality looks like, and that payment should be aligned with that, meeting those quality metrics. So I hope that that's helpful.
Thank you.
I just want to call out about this particular thing. I think it's so interesting the way we talk about cost and payment sometimes. We have a health system that is best fit for our most empowered, most educated people. And so now we're going to talk about the incremental cost effectiveness ratio for good communication strategies, for patient empowerment, and for navigation. It's just kind of crazy making. But we have to figure it out. We do have to figure it out.
On that note, I'm just going to say, what about the radical notion that we look at patient navigation or other complex interventions in the same way we look at devices and medications? So if they're improving morbidity and mortality or some patient-reported outcome by which the FDA would consider approving a medicine or a device, can't we just apply that same standard to a more complex intervention? And I get this partly because you can make navigation cost effective if you restrict it to the most costly patients, right? If you say only these people who were costing this huge amount of money now get navigation and they actually come into care, it will be cost effective, right? But once you expand it to the larger pool of people who were maybe going to still come, but under a lot of stress and duress to the majority of their visits, but they can still benefit from navigation, it may no longer be cost effective. It may actually cost them money. And I just want to say I think that's okay.
Yes, typically we pay for benefits. We actually typically pay for value. And so it should be okay. I wish the FDA actually did that for devices. They actually don't. It's only safety. They don't require any evidence of benefit.
So 2 comments I just wanted to make. I recently started reading scientific articles differently. And after kind of 15 years of reading, I would read something and it would say, okay, so the control group, 40% of the people did what you want them to do. And in the intervention group, 80% did. So we have clear evidence that the intervention is successful, right? So now, after hearing someone at a recent conference, I realized, well, what about the 40% that are doing something without the intervention, right? So I don't know if everyone needs navigation. I do think our health system isn't intuitive, right? But how do we identify the people who are doing just fine and the people who really need help? So it's kind of, I guess I'm just creating, I agree with you, and I'm creating kind of a tension point behind this. I think some risk stratification makes sense. And it does make sense to what are the characteristics of the people who don't need the intervention to be okay and to do okay. And then the second thing that I wanted to say is one of the things I really loved in 2008 when I entered the survivorship space was it was new and everyone was trying to figure it out. And so everybody was like, yeah, I'll talk to you for an hour. I'll totally tell you what I did. Let's work on this together. And I feel the same way in the sexual and gender minority health space right now. We are trying to figure out how do we create a more competent spread capacity in terms of LGBT health competency. And I think, and what I've said in some of my writing is, I don't think disparities is a scientific issue. I think it's a political issue. We know what works and we know what we need to do. Do we have the will to do it? And the US health system is huge and it's complicated and it's different in different settings. But if we actually collaborated and stopped this zero-sum game, which it's America, maybe that's not possible, I don't know. But if we actually collaborated within particular contexts, we can do this. I mean, you know, a few years ago, the city of Memphis and the city of Chicago took on breast inequity. And they're actually making strides because they made a citywide commitment, right? And they said, okay, we're going to look at this candidly and we're going to solve this problem. If you decide you're going to solve it, we can solve it. So I think it sometimes is a matter of when we get to a certain point of progress, we start competing against each other. And when we're at those earlier phases where we're more likely to collaborate, so how do we actually look at this as a collaborative problem that we really actually want to solve?
I'm going to add one thing to this as well. So maybe we can loop back around to some of the discussions yesterday as well. So in a study we did with family members of patients with primary malignant brain tumors, one in which you would assume that every single caregiver would need some sort of support, we found that depressive symptoms over time, if you looked at the caregivers in the group, there are two distinct trajectories. One is people come in with high distress, and they stay high above threshold levels, and another that comes in low and stays low throughout the trajectory and have very low support needs. They, whatever it is, they have the resources, the support, the problem-solving skills, whatever it is, they don't need support. And I think part of our job is trying to figure out, and we do this through research and through clinical practice, who is it that needs, for whom do these things work and are they needed, and for whom do they not? So, and that's where the discussions about electronic patient-reported outcomes or patient-reported outcomes within the clinic are really valuable, right? If we do them in a smart way, in a parsimonious way, and we have action-based measures that we do for things that are above threshold, and I think that's a good way to be able to start figuring those questions out.
Sometimes in this spot, people assume that the health literacy community is saying, okay, well then screen for health literacy and then stratify and activate services based on that. And that's actually not been the recommendation. So the reason is it's just not patient-centered enough. It's just not context-specific enough. It's like, so you really have to take, I think, ultimately a patient-centered approach, figure out what the needs are, and figure out a plan that will be fitting.
Hi, I'm Christy Munger. I'm a breast cancer survivor and human-centered designer. First, I want to thank Heidi. I've never felt so understood as a patient in the burden and the work that it takes. I always joke that cancer was a full-time job for me, and I think you really articulated that well. Even as a survivor, it still feels like a part-time job. And I think it's important that we integrate what was in your presentation, Heidi, into a lot of the other topics that we're talking about. So for example, in survivorship care plans, I fully agree that they need to be rethought. We don't need treatment summaries. And I had a survivorship care plan that was this thick. I'm a highly health literate person. I'm really proactive. I'm a project manager. And I still found it completely overwhelming, even though it had actions in it. I think we need to turn to how do we incorporate behavioral science and behavior change and create tangible, feasible action plans, because we can only make one behavior change at a time in our everyday lives. And my other thought and challenge was around patient-reported outcomes. I'm a huge advocate of them. I created my own PRO system when I was a patient. But I think we really need to integrate some of Heidi's principles that she talked about into how healthcare systems actually design and implement their PRO programs. They need to be not just beneficial for the care teams, the physicians and nurses, and understanding what interventions that they need to incorporate, but it needs to actually be beneficial for the patient at the moment of entry. So how do we help them educate what do I do with this symptom? What's normal? What's not normal? How can I see my own trends on a day-to-day basis so that I can better manage at home, so that I can be empowered to sort of do things on my own and not need to call into the nurse's line all the time?
Great, thank you very much.
Deborah Collier, Patient Advocates and Research. So thank you all very much. I think this has been great, and I agree with the concepts and applaud your efforts to try to build more of a true team approach for the patients. I think it may be good to back up just a little bit, and I actually have some questions about how we integrate some of this into not only the knowledge for patients, especially based on the last comments, but also through health systems, because this seems to be where a lot of our glitch is. I didn't present the slide yesterday, but I have a slide that says, when you become a patient, it's like being thrown onto a new planet without a roadmap, dictionary, or survival training. And so those are the three areas that we need to be helping people with. Our health systems don't do that because they're not really health systems, they're crisis systems, right? And so, as a person and as a caregiver, which was very important to bring them in, I automatically think about that, but we don't always talk about them, and we need to bring them into the limelight as well. I've been both, and most of the people I deal with have as well. So I have one insurance company. I have at least 10 electronic medical health records. The only one who is trying to coordinate all of my information and care is me as a patient. I'm the one who has to tell every office I go to that I want my primary care physician to have a copy of my records. How there are systemic things we could do here that would help that part of the process for the information that my healthcare teams, plural, need in order to help give me the kind of care that we all would like to have happen. So how do we then bring in the systemic issues that we have and connect those to the health literate information and care that we want to provide?
I think ultimately people should be much angrier about the fact that we have not made the complete progress in interoperability. The public investment in this has been massive, and we have not gotten as far as it's against the business model of some of your providers to share your information. And so we should be quite angry about that. But Urmi Mala has shown that this is a safety issue, so I don't know if you wanted to comment about this.
I would say that I think a lot of health advocacy is focused on really concrete things that people are experiencing in their everyday life that are the consequences of policies, right? And so I think that what happens is that people are upset with a large bill, which they should be. I mean, I think I'm not saying that that's wrong, but I think, or a specific disease condition, or a specific challenge. But in reality, I think it would help to have a lot more public advocacy around the flow of health information, because it's difficult to overstate what a significant impact that has on both patient and caregiver stress. I remember a friend who was very, very ill and was calling her primary care physician to talk about a recent emergency department visit, and felt really frustrated that her physician didn't have the records. And her physician said, you need to call the ER and get the records. And she expressed so much disappointment to me about that physician. Why didn't the physician call and do it herself? And I said, well, if you don't sign a record release, she can't. And my friend had no idea that that was not possible. And so she felt like, she wasn't a good doctor to me because she wouldn't just get my records. She was making me do stuff, and I was already sick. And this kind of misperception and this lack of understanding about how the lack of portability of information is impacting people's health, it prevents the kind of advocacy that we need. The EHR companies are huge behemoth businesses with a ton of power, and physician and provider groups have not been able to take them on successfully. And I don't think we're going to unless we engage the public.
Yeah, I'll just mention one of the things that we do to help present a clearer picture for physicians about the members, the members' care that they're getting. And so, each of our members have the opportunity to opt out of sharing this information as well. But when a physician looks at eligibility and benefits, right? As someone is starting to come into the office, we serve up what we call a member summary that's for the physician. We have these types of member summaries of health history and whatnot for our members as well. But we serve that up for the physician so that they can see, this is what this patient has done, who else they have seen, what else has been ordered, and then that at least makes them more knowledgeable about that and can, maybe ask the questions and help to, see the other records or whatever else that they need to see with the permission of the patient in order to aid in their care.
The problem is that is logging into another portal, going to a different place. It's not something that a physician can do in the course of their everyday work.
Right. It's their, the physician's not checking the eligibility and benefit, right? It's somebody in their office. But, we try to make the physicians aware that this is available and try to make the office aware of, the need to print it, provide it, to give it to the physician to aid them.
So I don't have a solution to interoperability, but I did want to make a comment about systems change. I took a slide out of my presentation that was a picture of a mountain and with a trail up the mountain, and the emphasis of that particular point was partnering for systems change, that in navigation you can address individual level barriers, but back to this creating a culture of trust and transparency, if navigators are not able to communicate problems that come up again and again and again because they're part of the system, then you're wasting time, right? And I can give you an example of, and then I guess also being open to being wrong is important. So I can give you an example. In 2012, I brought about 50 stakeholders together. And I remember our Medicaid office was insistent that transportation was not an issue for patients. And our navigators were insistent that transportation was an issue for patients. And because on paper, Medicaid covered transportation, they're like, this is not a problem. We have a program, right? But what we were able to discuss was that how that problem wasn't working in practice. It had good intentions, and it was supposed to work. But what was happening was it was still taking patients a half a day to get to treatment, or there were all these things that weren't working. So then we were able to kind of address and improve on that system because we could talk and people could hear each other, right? But if we don't have that kind of culture, that doesn't happen.
Thank you. Gwen Darien, Patient Advocate Foundation. So actually, Mandy, we surveyed our patients, the patients that we serve. We serve 150,000 patients who are low income, underserved patients with serious diseases. And the number one thing they call us about is transportation. So just as a little support for what you were saying, and it doesn't matter. Urban transportation and rural transportation are very, very different things, and it can take just as long and be just as stressful. So I wanted to go back a little bit to something that had been talked about in terms of working at the top of a license and integrating this team-based approach, and the fact that patients say that they want to see their doctors. But I would push back on that, and patients say they want to see their doctors because of the incredibly hierarchical system where the other members of the team are not given the level of respect and empowerment. So the team members have to be empowered, not just the patients have to be empowered. And so if you go to a doctor's office, and I have one of my doctors, I'm a 3-time cancer survivor, is a wonderful surgeon. I call him doctor. He obviously clearly respects his nurse practitioners, who I see mostly, but they're all called by their first names. It is not just a problem of the patient saying that they need to see the doctors. It is a problem of the system making the doctors at the top of that pyramid, and everybody else having a lesser sense of authority and responsibility, and that is communicated to the patients. And I think that's one of the biggest reasons why people and patients ask to see their doctors if they are, unless they have been in the system for a long time and realize how phenomenal nurses are.
As I mentioned, I just did an ethnography of high-performing primary care sites, and I will tell you, I'm going to give you a quote from one of the medical directors of one of the sites. She said, well, it's the medical assistants who really run the clinic. We see the patients and make the medical decisions. And I will also share with you that I had a deep envy in that moment of practicing in that setting. But I think you're right. You have to be willing to devolve. And the doctors in that practice, they had to accept the fact that the nurses and the medical assistants added patients into their schedule if they needed to be seen.
Yeah, I completely agree. I mean, there's a reason why there's the hierarchy. I mean, the kind of the way that people are educated and the pressure that physicians feel, the level of confidence physicians feel they need to convey to avoid being sued. I mean, I think all of that is important to consider. I think the really critical piece is helping the patient understand who is expert in what, right? So, the physician is not the expert necessarily in your mental health or in helping you deal with your insurance company or helping you identify the best diet plan. So I absolutely agree with you, and I think it's about communicating, again, the role and who has expertise and is really the expert in what.
But I do think that in a lot of cases, it's the physician who is at the top of that pyramid who has to make sure that they communicate that and empower the team, rather than assuming that the patient is going to, when they ask to see the doctor, it's because that's the way the system has been set up.
There's also just a tremendous array of different contexts. Something on the order of half the doctors in the United States work in contexts where there are fewer than 5 clinicians. So
I'm the daughter of a doctor,
yeah,
so.
Yeah, right. So it really depends on the context. And yet, at the same time, if everybody from the physician to the patient can't have a voice in this and can't express dissatisfaction, if you bring this back to the health literacy side, I want the patients to be able to express dissatisfaction. And you go to the pharmacy, you can't get your medicine, you should be able to say, I'm dissatisfied. Fix this problem. And everybody through the whole thing, or else the hierarchy is silencing people. So,
after all these comments, I'm not sure what comment I'm trying to make now, except the adage, it takes a village, and the United States is built on autonomy, and the two don't mesh, because when you're sick, you need the village. But we don't have a system that incorporates that need. And whether it's the team of professionals, or it's the team in the community, or it's the team in the household, we don't address the group. And that leaves the patient on their own when they come to the hospital and cross that threshold. They're expected to speak for themselves when they're speaking for a whole group of people who are helping them get through this. And often the clinicians go in it for all the right reasons. It's the system and the structure and the profit-making vision of the institutions they're working in that go against what we're all trying to do, why we all went into the areas that we work in. And, everything the panel has said is so true, but how do we change that system to be more responsive for why we all do what we do every single day? And garner that expertise. There is wisdom in the community. And having worked with navigators for the last 30 years, our navigators are unique in the sense that they are the community workers. And then they transition to the hospital, and they've learned all the lingo for the patients that they're navigating. They know the home circumstances, so they can help the families transition really beautifully. And the clinical staff has become very dependent on them. One, it's the translation issue, but also the expertise. And they know what questions the patients need to ask without the patients knowing that they need the information. So they're there to ask the questions as well. So it's those kinds of best practices that I think we need to restructure our system with, but the system itself has to change to acknowledge the vast expertise that's needed to treat such a complex disease as cancer. And, cancer was at the vanguard, then AIDS took over and really, made the final charge to break through. We need to look at all of the chronic illnesses and try to figure out better ways to support our communities and who support the patients through this experience, and have everyone, rather than competing against each other, to work in the benefit for our patients and their families. So,
but maybe before you leave the microphone, do you advice about culture change? Because culture is going to eat our strategy. So how are you going
Not
to?
unless it becomes our new strategy. We're creating new worlds all the time. That's one of the benefits of culture, is that it's flexible. It helps you adapt to a new environment. So that's what we're doing, but we have to acknowledge what was so we know what needs to be changed. And then forming collaboratives and gaining the expertise of many to be able to move it forward. The model that Humana has I was just astounded. I think it's fabulous. And we could have more gatherings like this where they're really work sessions to look at policy change, to be the advisors to whomever is sitting in those political seats, to be able to move this forward. Because as it is now, we're going to go broke. With the new treatments that are coming out in cancer care, one patient is going to wipe out, maybe that hospital's brake line. How are they going to afford that? If we've got low-income, low-literate populations, are they even going to have that treatment accessible to them just because of the cost? We don't have insurance companies that are going to cover that for patients. What are we going to do at that point? So these aren't existential questions. These are really practical questions that we're at the brink right now, and hoping to turn to all of you for some real solutions, or at least ideas that can be implemented to make the change.
So just two thoughts. I completely agree with you, and I would say advocate at every level continually, and be respectfully brave in countering things that don't make sense and are disempowering or against what we're trying to accomplish. Beyond that, I know I was very, very active in advocacy a couple of years ago, and then the rest of life took over, right? And advocating at every level for what you see as the change that needs to happen. That's all I got.
Hi, I'm Tony Bach from the University of Washington. I have two comments. One is to follow up on Dr. Kagawa-Singer's thing about new cultures and how to change them. I think there's a really important role for having experiences where clinicians go to other microcultures and see what it's like to work within them. It's not enough for them to go to trainings where they just sort of see the idea on the PowerPoint. And I feel like one of the things I've learned in training physicians to communicate better is that putting them in new situations and allowing them to see what success looks like is really powerful. And that is the kind of training which would be a kind of team training in how do you deal with patients who have low, different kinds of cultural literacy. That feels like it's a thing waiting to happen. The second thing that's a comment. The thing I was going to ask, though, is like Dr. Sarkar, I work in a safety net hospital, and I feel like I see different kinds of health literacy issues that really haven't been named very well, and I feel like that would help the discourse. So I'm interested in the panel's reaction to this. So, for example, I feel like I see patients who don't really understand the instructions they're given because we're giving them at, 15th grade level, and they understand things at 6th grade level. I feel like I see patients like the one that Dr. Sarkar just mentioned who don't have an understanding how the system works, and they misattribute things, different causal things to things in the system, and that creates frustration and roadblocks. And then I see patients who, honestly, they just have different ideas about how the body works. And I find myself in these conversations realizing, halfway into usually the second or third conversation, honestly, realizing where the issue really lies. And I haven't heard a lot of talk about how these different kinds of health literacy play out and what different kinds of interventions really benefit them. And I'm just curious what the panel thinks about this. Thank you.
I'll start just because I think I took out the slides about the definition of health literacy and how we conceptualize it from my talk this morning because I knew it was the second day and it was in about 5 of the presentations yesterday. That said, I think of health literacy as kind of like a window through which all information or all communication passes, right? And so the kinds of things I would suggest that the different things you enumerated, comprehension of instructions, and understanding how the body works, beliefs about causality, are all passing through the lens of a person's health literacy, rather than each of those being a different kind of health literacy. And in terms of measuring health literacy, we talked a lot about, should we be measuring trust? Yes, I think we should be measuring trust, but I don't think trust is a type of health literacy. I think health literacy is actually a cognitive processing capacity that our patients have to different extents, and there are different ways of measuring it. Some are through cognitive testing, right? Those are what I call direct health literacy measurements. But then there are proxy health literacy measurements, including self-reported health literacy, and those questions have been validated. And you can use one item. It's not great, but it's decent, and it's been validated in Spanish and in English. It's how confident are you filling out medical forms? And that's actually a pretty good proxy for long and complex direct measurements of health literacy. So I think as we're thinking about health literacy, if we think of it as the window through which people are processing health information and tasks that come at them, that helps us understand how to talk about all these tasks vis-a-vis health literacy. That was a very academic answer. I hope it was helpful.
Ultimately,
I get it conceptually, but it seems big and vague to me as a practicing clinician.
But ultimately, if you need to talk to the people. You need to talk to the patient. You need to find out where they're at. And like a guy said to me in the clinic the other day, I did exactly what you said. I don't eat red meat anymore, which I hadn't said to him exactly. But he said, yeah, I cook it all the way through. So, you have to talk to people and understand where they are, where they're coming from, what they're doing. But with that, where we are going is to break. So thank you very much.